So, good evening, everyone. I'm Dr. Hanish Gupta. I'm a specialist physician from St. Stephen's Hospital, Delhi. This was supposed to be taken in the morning, but my flight got delayed, and finally, I'm taking it now. And thank you for giving me this opportunity. This is the second time that I'm coming to Chennai, sharing my experience and my expertise with you. Today, the topic that has been given to me is hepatic dysfunction. The qualification of in diabesity is my own addition to it. But we all know that we have got in the field of diabetes up till now, cardiologists sharing the podium with us. Then the nephrologist came and they started to share the podium with us. And now it's high time that even gastroenterologists would come and share the podium with us. It's because more and more, as we see, the solutions are coming to us. Earlier, we did not have the solutions, we did not have the diagnosis, we did not know what organ is the victim and what organ is the perpetrator. But now we know that hepatic dysfunction plays a huge amount of part in the way the outcomes of diabetes patients they fare over a long period of time. So just to give you a perspective, this is the scale of problem all over the world. We find that 70%, more than 70% of type 2 diabetes patients have got fatty liver. But just by saying fatty liver, that doesn't qualify them to become diseased. They have, out of those 70%, around 50% would have progressive MASH, which is steatohepatitis, and 1 in 5 would have an advanced liver fibrosis in type 2 diabetes, and 55% of these projected MASLD prevalence would actually keep on increasing, and that's just a part of the problem stated. Now, if you look at the prevalence and incidence in India, the prevalence of MASLD in general population, it varies from 9 to 53%, and geographical and rural urban differences in this prevalence is quite huge. So whereas the global prevalence for lean MASLD is 7%, the Indian prevalence is much higher, it is 16.9%. And almost the alarming point out here is that if you find adults, they are having 38% MASLD. But look at kids, look at children. They are having 35%. This is our future, and they are already grappling with this problem. And this is a problem which we have not addressed till now. Now, if you look at pathophysiology, what happens? People are having fatty liver. You find people coming with ultrasound saying that this person is having fatty liver, grade 1, grade 2 fatty liver. What does that actually mean? First of all, you need to understand the pathophysiology. See, whenever the patient is having hypertension, obesity, hypertriglyceridemia, or a low serum HDL, or for that matter of diet which is having highly unsaturated fatty acids, free fatty acids, these people already have the first hit. What is the first hit? They start accumulating the fat inside their liver. So it's like their liver is ballooning up with fat. But does that become a disease in itself? No, it doesn't. Unless and until there is fibrosis, there is scarring, there is no disease. So just by a patient coming to you with an ultrasound saying this is a fatty liver, it means nothing. But if they have comorbidities like hypertension, obesity, hypertriglyceridemia, then it really becomes a problem, because that is the first hit. What happens with that fat that is ballooning their liver cells? It starts to become toxic. That lipotoxicity and mitochondrial dysfunction, that leads to the structural abnormalities. So till the point of time that there is no scarring in the liver, whenever I say fibrosis, think of scarring. That's the word for it. So whenever there is accumulation of fat and that fat is not getting handled well, and intracellularly the mitochondrial dysfunction is leading to the destruction of that cell, it leads to scarring, that leads to fibrosis, and that is where the hepatocellular inflammation and steatohepatitis it becomes. So till the point that there is no inflammation, you don't have a problem. But point where the inflammation starts, that's where the problem begins. So if you treat diabetes but you ignore the liver, you're actually missing out the disease, because it's a silent progression. It is not going to knock on your door. Other diseases, they have a problem. You have a cardiovascular problem, patient will come to you, they will have swelling, maybe on their face, maybe on their legs, they will come with shortness of breath, they will have decrease in stamina, they will have vague kind of complaints, which will all, and then there is patients who are heart failure with reduced ejection fraction, with preserved ejection fraction. There are so many other things. So half of the lifetime of research has been spent on finding out the cardiovascular tenet to the effects of diabetes. Nobody was thinking of the liver at this point of time. Of course, there is a cardiovascular link. The disease, cardiovascular disease is also the number one cause of mortality in MSLD also. And the liver-heart axis, it also amplifies this metabolic risk exponentially. And it is the top indication, by the way, please remember this, and this is a really big thing because the burden clearly specifies in one word that MASLD is now the top indication of liver transplant in US for women and patients with HCC. Now we emphasize here for women because women, they don't drink as much as men do. So still for the men, it is still alcohol, but for women definitely, for the liver transplant, it has become, MSLD has become the number one cause for transplant. So what happens in this pathophysiology? The problem is that liver becomes both the victim and the perpetrator. So because there is insulin resistance, there is more lipolysis, there is more free fatty acid influx into the liver, there is mitochondrial dysfunction, there are reactive oxygen species all around, the gut-liver axis is getting affected, there is de novo lipogenesis, and the inflammatory cascade is the one that leads to the fibrosis, which I would always say that you have to recall the word scarring always. It's going to begin again and make the liver more and more damaged. So this is the disease spectrum. You look at this, and this is quite easy to understand. One is steatosis. The patient is coming to you just with plain fatty liver, nothing else. But once inflammation sets in, then it becomes steatohepatitis. And how do you come to know about steatohepatitis? Because there are several other things which we will allude to as we will progress. When there is significant fibrosis that is more than F2, which is biopsy proven, the risk becomes super high. And after the advanced fibrosis or cirrhosis, we all know that the patient is going to have a liver failure, which may require transplant later on. So it is becoming, like I said, a growing indication for liver transplant, especially in the United States. The fibrosis stage is the strongest predictor of the liver-related and all-cause mortality, and normal liver functions, they do not exclude. Please remember this. If a patient is coming to you, SGOT, SGPT normal, don't believe that they are just having a normal liver. That is the biggest pitfall. Never believe that, never buy that. There are several other things that you need to be looking at. This is our past, what we used to do. We used to diagnose, by elevated transaminases, which used to miss out on a lot of patients. We used to look at the ultrasound of the fatty liver detection. There is operator dependent, there is missing fibrosis. There has been series in which they have found that some radiologists, they have never ever reported a normal liver. Every time an ultrasound came to them, they always reported fatty liver grade 1, grade 2 as per their own discretion. There have been, or we have always believed that liver biopsy is the gold standard, but there is sampling error. It is not scalable. You enter into the place where there is no fibrosis, there is no scarring, you miss out the diagnosis. It doesn't happen like that. And how many samples can you take in a liver? You cannot keep on poking the liver to find out the samples. And that's why this late recognition was diagnosed only at advanced stages. What was the treatment advice that you were giving them? Weight loss. Just go home, take vitamin E, take pioglitazone, try to lose your weight. There was nothing which was absolutely pragmatic, which was scalable, which was dependable, or you could say it was measurable. You could not say that. So we treated late, we diagnosed late, we had no targeted therapy for the liver disease in diabesity. Now what is the present shift? How did you shift from there? First of all, you removed the stigma of alcoholism. Metabolic dysfunction associated steatohepatitis can also happen in people who are taking alcohol. So why do you always see that it has to be non-alcoholic liver disease? So you just remove the stigma, you emphasize on the metabolic origin and align with the diabetologic practice, and that's why you came up with the nomenclature of metabolic dysfunction associated steatotic disease. If there was steatohepatitis, you started to call it MASH. And who should be screened? Definitely all the type 2 diabetes patients, definitely all the obese patients, and also the patients who had got prediabetes with a family history of liver disease. Now this is a very wonderful algorithm that was given by a joint statement from European Association for Study of Liver, European Association for Study of Diabetes, and European Association for Study of Obesity. Very simple. Go for a steatotic liver disease, go for the imaging. Somebody says, okay, this patient has got fatty liver. You look for the presence of any cardiometabolic criteria, if it is present, like there is type 2 diabetes, hypertension, hypertriglyceridemia, you just go for asking the patient that whether you consume alcohol or not. If they consume alcohol more than 20 grams a day in women and more than 30 grams a day in men, then you label them as metabolic alcoholic liver disease or an alcoholic liver related disease. But if they are not consuming it, then you have to look for inflammation and ballooning on histology. And histology, I know that it's not possible for everyone to go for this modality, but then there are other ways also to go for it. If nothing is there, there is nothing, then you have to think about drug-induced liver injury. You have to think of other diseases like cryptogenic liver diseases. Now, this is a practical clinical algorithm every type 2 diabetes or obese patient should follow. You screen. First of all, you screen. Once you have screened, go for the FIB-4 score. Because FIB-4 score is very easy. You can have a FIB-4 calculator. If you find out that the FIB-4 score is having a cutoff of more than 2.6, definitely that patient goes for a fibroscan. Now, most of us, we don't understand what is fibroscan. Try to understand this. You are not giving a needle inside the liver. All you are doing is a mechanical, there is a ray, a laser ray, which is going inside. Now, if the liver is spongy, it is elastic, it will travel very slowly because sound travels through the denser surfaces very fast. So if the liver, on the other hand, has become scarred, it has become fibrosed, it has become very dense, it will just go very fast because sound will travel very fast through the dense surfaces, and then it will just give you an cutoff value which is more than 7.1, and that is from where the whole picture starts. We have not used the needle, we have just used a sound wave. The sound wave has traveled to the liver and it has given us the exact picture that what is the density of the liver. Now, it works very well for us, all of us. So for the cutoff for any kind of a liver discussion would be 7.1. If it goes beyond 12, it becomes moderate, and if it is between 8 and 12, it is moderate. If it going beyond 12, it becomes significant fibrosis, and that is how you risk stratify. That is how you decide that what do I have to do for the patient. If the patient is F0 to F1, you are going to assess the patient annually, tell them about lifestyle management. What lifestyle management you are going to tell them, we'll discuss that. If it is F2 to F3, you have to consider medicines like resmetirom. It's not available in India, but then again, we should be aware of it because sooner or later, it will also come to our country. If it is cirrhosis, then of course, if it is F4, you have to have a hepatology referral urgently. So you have to initiate the weight loss strategy, the GLP-1 receptor analogs or dual incretins, SGLT2 inhibitors, and consider resmetirom. Now, this is the screening guideline which has come from the Indian National Association for Study of Liver. You look at incidental detection. Now, this is customization for our country because we will depend a lot on the liver transaminases. If there is an incidental elevation of elevated transaminases, you screen for fatty liver, look for hepatic steatosis, which is evident on ultrasound, and then rule out the other causes of hepatic steatosis or elevated transaminases, and then definitely go for a FIB score. And that is where they say that, okay, if the FIB score is, beyond 4 or 2.67, then that is where the treatment starts. Now, this is the menu card for the anti-diabetic medicines which have got hepatic benefits. We have got GLP-1 receptor analogs, we have got semaglutide, which is going to show very soon in the Essence trial that there is going to be not only just halting of the MSLD cascade, but also there is going to be reversal. For the dual GIP, that is tirzepatide, we know that there is going to be superior weight loss, there is going to be strongest hepatic fat reduction, and the Synergy NASH trial is also going to come, which is also again going to show the fibrosis improvement. SGLT2 inhibitor, well, we all know it's a drug which we all have developed comfort zone with. Very good. There was a e-lift study that was done in Delhi by Dr. Amrish Mittal that also clearly showed that there is going to be reduction in liver steatosis, reduction in liver enzymes and liver hepatic inflammation. A word about this wonderful drug that has come out by the name of resmetirom. This is the first ever drug approved for MASH with liver fibrosis. What is it? It is an oral selective thyroid hormone receptor beta agonist. Now, if you have a confusion, yes, it is a hormone receptor agonist, but it is not an alpha agonist. All the benefits, all the systemic benefits, like, if you are giving a thyroid hormone receptor agonist, you believe that, okay, there is going to be, huge shift in the BMR. The patient is going to have tachycardia, they are going to have sweating, they are going to have increased bowel movements. All those benefits, all those actions, not benefits, all those actions, they are perpetrated by the alpha agonist. The beta agonist, they are located in the liver. So it's like, you have put the furnace in the liver. The whole system of the body is not getting affected. The systemic effects are not coming, but the body is having a furnace in the liver, and the liver is burning out that fat very quickly. It's like that. So if you have a house, there is a furnace. The furnace is giving the supply of the heat everywhere, and the burning of the fat is actually happening only in the liver. Just to complete, these are the future emerging therapies and the precision medicines that we have. The last 4 medicines, they are the ones which are still having ongoing trials, phase 3 and phase 2 trials. And the bariatric surgery is a defining option for MASH resolution, for, of course, fibrosis revolution, and that reversal, and that has always happened. So just to clearly put some key take-home medicines. See, first of all, awareness is very important. Don't believe that you can treat diabetes without treating the liver. It's the place where every action is happening. Screen all type 2 diabetes and obese patients alike. Use FIB4. It's very important. Every doctor should have a FIB4 calculator. It's very easy to calculate. It just put the values inside and you get the cutoff. The science is that insulin resistance and lipotoxicity, they are driving the disease. So fibrosis stage comes very late. If you look at the risk factors and treat the patient, you can just protect the patient from morbidity and mortality. And the liver cells will become a standard diabetes complication managed alongside nephropathy, retinopathy, and neuropathy, which I already elucidated in the beginning. This is how things have happened. The past, we had liver as a silent organ. We kept on ignoring it. The present, we have just started to understand, and future, of course, will actively treat and prevent. Thank you so much for your patient listening.